I'm happy to introduce Joe Orsini from New York State Department of Health. So yesterday, we had our newborn screening roundtable, which is always a great discussion. And Joe has the honor of taking 3 hours of information and updates and condensing it into about a 25 to 30 minute presentation. So Joe, thank you so much for that. And thanks for being here today.
You're welcome. Thank you. It's my pleasure to be able to do this. I think it's a great experience for all of us in the newborn screening ALD area to be able to meet like this. So thank you for providing that extra time for this meet, prior to the meeting for this. Do you want me to show the slides? Share my screen, or do you have them? I can share mine.
You should have privileges to share.
Okay. So there's my multifaceted screen. Why is it that all of this stuff comes up every time I want to do something? Close down a few things and get to what I need to. There we go. It was hidden. The corner was hidden. So. Is this working?
Yeah.
Yes, perfect.
Okay, great. So this is year 6 of the roundtable discussions, and it's really been, I think, valuable for me personally, and I hope all the other states involved, as well as people that are having to kind of do some of the follow-up associated with newborn screening for ALD. So yesterday's discussions were lively and maybe have a similar theme to past years, but I think we're still, when you consider ALD, the symptomatic cases for especially the cerebral form of disease are going to be 3 to 7 years out. We're starting to hit now where we're going to start seeing some cases, and it's still early yet. So we're still working a little bit blind in newborn screening, and that's sort of where a lot of this discussion comes from. So just a disclaimer, this is a summary of the discussions from yesterday's roundtable discussion. I might have interjected 1 or 2 things. I would like to say anybody who, I'm hoping I can get through this quick enough that if others think I missed something and would like to add, I really would appreciate that. Certainly apologize for that. But so let's go on. Let's see. Oh, I feel like I missed a slide there. Hang on. Okay, well, so there were 44 participants in this meeting, and one of the things we do at the meeting is all the screening programs will share their data, and the states you see here were involved actually yesterday and were able to share data. There were some other states that weren't present that shared data as well. So we're finding our oldest positive boys are now plus or minus 8 years old. So it's been going for 8 years. So like I said, it's kind of on the cusp of where, we should be picking up individuals with cerebral form of disease or other forms of disease. And we are seeing some of that. So just a little bit of the history, I think was briefly already discussed. Back in February 1, 2016 is when this ALD was added to the RUSP, and so it's been almost 7 years since that was approved. Right now, well, whatever it is, 2016 till now. Let's look at, this is just a progression of how ALD's gone since then. So 2018, we had 2 states, adding more states each year. The reason I'm showing these slides will be apparent soon. 2020 is 18, so we had a lot. 21 up to 20 is about 61% of the babies born. Now you can see the 20 states here is a little off from what Elisa said. Up to 20 in 2022. This is just something I ran the other day. It was 21 states. And what I want to say is, if you don't see your state on here, if you want to go to the next step, new step screening page and update your information, because as we learned from Elisa, there are now 25 states, which represents over 65% of babies born. So this is, it's just a little bit of a lag in what's reported out there. So if you want to have it accurately reported on new steps, you might need to check that. So that's the status of screening. We look for representatives from all of these states to provide updates at this meeting. And some of the states, the New England states, are actually, I don't think are necessarily screening themselves, like Maine, New Hampshire, Vermont. I think that screening might be taking place in Massachusetts. I'm pretty sure that's what's going on because they do all their other screening. So some of those states weren't represented yesterday. But we'll come back to the state updates in a minute. And there were some other updates that were important for this discussion. For those of you who maybe know, there's a CLSI document on ALD screening, and that was called MBS09. That was published in 2021. And for state programs, I refer them to section 6.2.4, which is really setting cutoffs. And that particular thing is one of the trickier things to think about. And anybody starting screening has, that's their big hurdle, I guess, with starting screening. Where do I set my cutoffs? There'll be a little more talk about that later on in the relevance to this document in a minute. So we have, I gotta get rid of something here. So another quick update, about 3 or so years ago, we started a project here in New York, and it had to do with some of the things we were noticing with how differences in between labs were with cutoffs, and how that was leading to kind of varied screen positive rates and detection rates. And we thought it would be important to kind of try to get this thing off early. And there are 10 plus participating states. The priority of this group this year is to get a manuscript written. And I say that's my priority. And we've got the group is going to meet about this. And a lot of the concepts that came out of the group ended up in the CLSI document, the MBS09 document. So a lot of our work made it into at least one document, but we want to have a manuscript and a publication that's more dedicated to the whole harmonization process. So that's what's in the works and is a high priority for me for this first coming months of this year. Got to set up a meeting with the participants. This is in process as well, and should have a meeting within the next month. And part of that process is just going to be to go through a lot of what we just did at this meeting, just get all the numbers squared away on state screening and how it's going. And then we're going to dig a little bit into reviewing any of the latest cases, especially those near detection limits, and how we want to report those kind of as examples of how we evaluate cases and screening. So in the course of talking about given these updates, and so I'm putting these slides sort of in a funny order, but we got into about a 10 or 15 minute lively discussion on cutoffs. So it didn't take us long. And this is, I think, the bane of newborn screening's existence is where do you set those, and what are you detecting, and what should we be detecting? And we're used to a newborn screening being able to have, once we provide a positive screen to our clinicians, to at least within a few months or a few weeks, get some kind of a diagnosis back. And with ALD, because there's such a long period of time before individuals become symptomatic, and in many cases, it's years. In most cases, it would be years. The feedback mechanism makes it difficult. So one of the things that came out really early was Stefan Kemp mentioned a point about cutoffs being too low. And this happened in his country's screening in the Netherlands. They were doing a pilot study, and are doing a pilot study. They started to pick up they picked up one particular case that really was troublesome because it was, it's troubling because they don't want to detect individuals that may never develop ALD, but the child looked like it could potentially have ALD with very borderline results, had a variant of unknown significance in ABCD1 variant. And this led on to discussions that what we're finding is a lot of labs are finding we're finding that people get diagnosed based on very long chain fatty acids being elevated in the newborn period, but we're not always sure what this means. In the world of clinical chemistry, it always, if somebody had symptoms, then it was almost certain if this is elevated and there's a variant in ABCD1, that it starts to look more and more like ALD. But in the case of being way ahead of the curve, like years ahead of a clinical, any clinical symptoms, these things become more, end up in a gray zone. So sometimes what we're finding in screening is we're finding our screening results are actually quite a bit lower than what we were finding in individuals with known clinical symptoms. But meanwhile, they look like ALD cases. So one of the points that came out is from Dr. Raymond was need to better understand the impact and number of these cases being detected. Or in other words, are we worrying about something where there's not really big numbers of individuals that are in this category? And I think that'll be something that if we can try to figure out for the harmonization paper and get a better idea, it will be good. The other thing that's been an issue and pointed out by many labs is the commercial labs have variable cutoffs for very long chain fatty acids. So it's, even in the commercial labs, and this has been pointed out before, there's not really harmonization. In fact, it's probably more or less likely they'll ever harmonize because these are commercial labs and they have, they all kind of work in their own little areas. I don't think they have mechanisms like we have to get together and evaluate. So these variations are not helping us in our processes with newborn screening. And sometimes we find, that the labs don't even necessarily have reference ranges for babies, individuals in a newborn screening period, so it even makes it more tricky. Everybody was talking about the importance of when you have these cases or any case really to do a real extensive family history, to look further into the family and the paternal side and or maternal side and determine if there are any family members that have ALD that were either unaware of this and this is happening, where people, older family members that are having troubles were never diagnosed. Then there are some where the family members are maybe more mildly affected and weren't even thinking they had ALD. So this is stuff that needs to be evaluated by physicians, and it takes quite a bit of time and effort. And we're not always certain this is happening. So this needs to be, continually, I guess, remind our physicians that this is a necessity. One thing that didn't really come up was the idea, we talk about boost versus pathogenic, but in my experience, and this is something that we didn't talk about yesterday, not every pathogenic variant necessarily carries the same weight. And if you look more closely at what's been reported, sometimes you find family members that have the variant have elevated marker, but they were asymptomatic females, and then that variant is now considered pathogenic. So you have to be really aware of what does it mean to be pathogenic, and what is that impact expected as far as childhood form of disease or more severe forms of disease. It kind of goes against the grain of ALD thinking, but it's something to keep in mind. The other thing we talked about is potential of using a functional assay for borderline cases. This was just briefly discussed. There aren't many cases where this is going to happen, but the trouble with this particular test is that it requires doing a skin biopsy, and that's obviously kind of invasive testing. But you have to weigh it compared to doing kind of a lifetime of MRIs. And will this functional assay actually reduce the need to do that further follow-up. And we haven't really done enough testing to say how helpful it will be. So that's something that people thought would be useful to kind of pursue more, as if possible, in the centers where it's possible. So even though we have these cases that we really don't know what they mean, we're still obviously recommending that there be continued to be followed. So this was rather long, I guess, diversion from our where we were going to go. But so the cutoff discussion came up a little bit earlier than we anticipated, but that's where all of our hearts are set, I guess, in this case. So now coming back to the state updates, rather than go through every state's individual data, I took the summarized data that Lisa had collected. And what we've got is, if you look at across the states, we see males with incidence rates as high as 1 in 5,250, and as low as 1 in 28,000. Females fairly similar sort of ratios. And then overall, anywhere from 1 in 5,000, 1 in 26,000. So just to remind people, kind of the reported or the incidence, prevalence, whatever, is reported typically around 1 in 17 to 1 in 20,000. So we're not far off. We're 1 in 5,000 sounds like a big difference, but those, if you look at the overall, it's somewhere, probably the average is somewhere in the middle instead of this range. So what about patients that have developed disease? As I mentioned, this was a subject, and we didn't get very far with it, so I figured I'd include it on this slide. Only 3 states thus far are reporting newborns or patients that have developed symptoms, and thus far only 2 that I know of that have been treated for cerebral ALD. And there are several with adrenal insufficiency across the 3 states. So I guess we didn't talk about this, but it's a question that still remains. Why is there such variability, 1 in 5,000 to 1 in 28,000 kind of thing? It's an early number for some states. We are looking at different tests and algorithms that may be picking up more potential positive cases because of different cutoffs being used. Being somewhat of a downward trending, I think it's stabilized now with where the cutoffs are. People are, there are enough states doing this that we're in enough background that we're kind of, I think the newer states are coming in kind of close to where other states have been screening. But the biggest factor is probably the case definitions for ALD. There's still, even in New York, we see very frequently physicians telling us that a child would have ALD based on the very long chain fatty acids and a variant in ABCD1. But, and these children should be followed. So it comes back to us as a clinically diagnosed ALD case, which from a physician's perspective makes perfect sense. But from the lab's perspective and trying to evaluate how they're screening, you have to maybe take it with, take a better or a closer look at what that means to you. And that's where we end up with a lot of these discussions. So what other things have been found? So first of all, you can go to the New Step site and get case definitions there. But I think, we've got in the CLSI document, it gives pretty good advice on how to consider these cases and how you evaluate them, and especially in relation to your cutoffs. But other than ALD, males and heterozygous females, there's a fair number of other disorders that are being picked up. One of the things that's sort of interesting is there have been a couple of childhood lupus cases picked up, I think 1 in New York and 1 in California, as a result of elevated C26 LPC marker in the newborn screen. And we'll be a little bit more on it. Some of these things are relatively straightforward to diagnose, and others are really would have not been picked up had it not been for really in-depth evaluation through next-gen sequencing or other measures like that. So some general discussion that we had was, there were some issues with how to set first-tier cutoffs. one of the issues there is that if you're not using an LC method and you use just the flow injection method, there's an interfering compound that causes your signal to be elevated higher than it ought to be for the amount of C26 LPC that's actually in the blood. And that causes really the mass spec's ability to quantify gets dramatically affected by it at the low end. At the high end, where you see individual, in levels where people are affected with ALD, this problem really isn't much of a problem at all. It's just at the low end, and what are we going to send for second tier testing? So we see a large variability across labs, and even within a lab, you can see differences from instrument to instrument. And the question that's still kind of remaining is how to handle that. What's the best way to handle it? And I think, especially for places where they have a lot fewer specimens that they're running per day, this can be a problem because you're kind of counting on the accuracy of your instrument to help you with this. If you have a lot of babies you look at every day, you can see trends where it's a lot harder to see trends with smaller numbers. Some people are using the top, say, X% with 1%, 2%, or 3% per instrument of samples. And highest LPC values are going on for second tier. So that's one approach, but that doesn't work so well if you're not doing even a full plate of analysis in a day, and if you have multiple labs that are actually trying to do this across your program. So one of the things I noted, it seemed like there was some bias between PerkinElmer or QSite numbers compared with that are run on Neobase 2 compared with people who are doing more homebrew tests with other instrumentation. And so we're not really sure what's causing that particular bias at this point. And then we did have some discussion about the screening for females. In Europe, it's kind of highly unfavored, but in the US, every state thus far is screening for both male and females. And the reasons for that are, just to say briefly, it's pretty difficult you can't count on what's written on a card by somebody as to whether it's a male or a female. There are mistakes, there are other reasons. So it gets very complicated to actually know who's a boy versus a girl, and you have to do some extra testing to do that, and that costs quite a bit of effort. The Netherlands have gotten that down, but their states really have not taken on that. There's some discussion of some states where people were concerned with screening females, and primarily because they're not going to become symptomatic until adults, and this kind of goes against the newborn screening dogma of trying to help somebody in a period of life where they're basically in the newborn or kind of earlier period. So lively discussion about that. Then there was another section of the meeting that was kind of dedicated to, well, what about these cases where this was presented by Christy Tyson, Amy Ponte, and sorry I don't have your titles on this slide. I apologize. But so as I mentioned earlier, there are other disorders picked up through newborn screening. And what do you do in the case where you have patients without an ABCD1 variant and you don't have a firm diagnosis? Or in the case where you have a variant of unknown significance, and one of the things that we have to be concerned with is that variant of unknown significance really a possible red herring? In other words, it's something that's present, but it has nothing to do with why the very long chain fatty acids are elevated, or it doesn't explain that, because there could be other reasons that they're elevated. And they talked about their approach in California with doing additional testing, either I think it was panel testing for the family, to be able to help the family get a diagnosis on their child. And if anybody is interested in getting that or isn't getting that in their state, Elisa has a flyer, I believe, and maybe I'm miscommunicating this, but so we can talk more about it if I don't have it correct. But Elisa has a flyer that will allow or help people to get that kind of testing done. So kind of my last slide is one of the things. We have this meeting once a year, and we do come back to this meeting, and there's a little bit of, from my perspective, of feeling like we saying the same things and not making a ton of progress. And then we all go off and we all kind of fight our own battles. So the idea is, came up briefly, is that maybe we should have more frequent meetings for the newborn screening crew. And I present this slide of where we meet to discuss and review borderline cases, our algorithms, our testing, and anything really. And then the proposal that Elise said was maybe on a quarterly basis. And I asked the question if there's an interest in this, and if the answer is yes, if you're interested, please let Elisa, ALD Alliance, or myself know, and we'll try to figure out a way of organizing something that where we can meet. And I know I have cases I'd like to go over and show people, I guess, show people why we end up in these quagmires and how we go about trying to think about it. And I'm not saying we have the answers, but putting our heads together to come up with what the answers might be, and where we stand, and how all of us can look at these things kind of in a more uniform manner. So that's my summary. I really appreciate, again, that Elisa and the ALD Alliance puts this on. I want to thank especially Michelle for providing me with the basic slides to work with that I could just update. And then, of course, ALD Alliance, the state programs for sharing their data, and the partners to help with our international partners and clinical partners that have helped with this process as well. If there are any questions, please let me know. Thank you.
Thank you, Joe. Are there any questions?
So, hey, Joe, it's Eric.
Eric.
I was wondering if Stefan was going to speak up, and I was going to beat him to the punch here. So I agree. I think reviewing these cases would be good. Can you give us a sense of, out of all the cases that have been screened that you know about, that have screened positive, what % fall in this VUS, elevated VLCFA, but no other phenotypic data as of yet? I'm just trying to get an understanding of the scope of the problem, because I have my professional experience with this conundrum, but from the lab side, I don't know. Is it 50% of the cases you're now identifying? Is it 5%? It would be helpful to kind of understand the scope of the issue.
Yeah, that's something that I think we need to nail down. I was looking at our cases, and we have 54, 55 boys that we detected with maybe CD1 variant, and almost all, if not all of them, with elevated very long chain fatty acids. We've gotten back from our physicians, I think somewhere around 30 of those are considered confirmed ALD. And when I looked at that group, 30 or so, I think there are about 10 of them, or a third of them or so, with the boost variants. And if you look at this is one of those things where I'd like to be able to show to the group. I didn't really want to get into it in the meeting yesterday, but if I showed it to the group, those are generally the ones that are kind of more at our lower ends of our screening. And then the ones where you look at where they're absolutely 100% unequivocal an ALD case, because it's like a large deletion, or a variant that's been well described with cerebral disease. Those are in much more elevated concentrations. And, so kind of the data is making some sense, but it's still only New York. And I don't know if a lot of other states have it that way. So it's really hard for me to, I think that's part of the reason where we have this harmonization group, and going forward, the idea of a consortium to look at these cases and pull them up in a blinded way. And part of the trouble is some states aren't allowed to share their data. So it gets kind of tricky. But, you know, for those that can, at least we can talk about that data in a way that everybody can start to talk about it in the same way.
Yeah, I
For our
think
state, 10 and 30 something, that's a pretty good sized
Yeah.
number of people that we may or may not be following. I'm not saying all of those looses aren't all the same. And just like you know, because the ones that matter are the ones that are kind of down at the bottom or closer, where we wouldn't, you know, should we be detecting them or not? The other ones that are maybe looses where they're really elevated, and you're going to detect them no matter what you do, because that, you know, you wouldn't want to be crazy and miss somebody with real disease because of somebody with a boost nearby, you know.
Yeah,
So I don't know if
I
other
think this is
states
really
have.
important. We had spoken about last year, and
I think it would be helpful for the two of you to define what a variant of uncertain significance is for the general audience.
Okay, yeah, so there's ACMG guidelines for determining whether a variant in any given gene is considered pathogenic, likely pathogenic, benign or likely benign, and then there's the one in the middle, which nobody likes, is the worst, is variant of unknown significance. So you can't decide whether it's benign or potentially pathogenic. And the rules associated with that really require, you know, what's the frequency of that variant in the gene, at what's been reported associated with that variant in the gene, are there known cases, how many cases, what are the sources, and you kind of add some weight to each of these things. And the more weight you put on it, the more likely it becomes either pathogenic or not.
But I want to be clear. A lot of the commercial laboratories do not take into account, when they're sending out the reports, any functional information such as elevated very long chain fatty acids.
That's right. Well, most of the newborn screening programs collect that separately, though. If you're sending out for ABCD1 variant, you're also sending out for a very long chain fatty acid.
I understand that, but many of the commercial laboratories will not join that information to use that in making a redetermination of the ACMG criteria.
That's true.
Right.
And on top of that, I have seen reports from commercial labs in which they reported a VUS, and it was clearly pathogenic. Either it was a deleterious mutation. I've seen a deleterious mutation being called out as a VUS because, according to the ACMG criteria, it had never seen before. So in population, it's very low frequency. And I would like to come back to that in the next sentence. But on top of that, they have, I've seen reports with clearly pathogenic mutations because we have 20 cases on the ALD database. So associated with ALD, but they don't use it. And I think that has more to do with liability and that kind of stuff. Another problem is that the ACMG guidelines, I mean, they're good, but the problem with ALD is that we have over 940 different variants, mutations. They're not even variants, but also pathogenic mutations. So the chance of picking up a newborn with yet another variant, eventually it runs out, because there's just so many variants you can have, but you can have quite a lot of them. So that there are many diseases in which there are very few variants of pathogenic mutations, and LD is I'm not sure if it's an exception, but it's on the extreme other end, which also complicates stuff. So there are many factors here.
I agree. I think, Joe, it sounds like this is important. I think flavors of this have come up over the years, but the recommendation of following the patients and following up and annotating what you have found in the lab with sort of I always mix up semi-annual versus biannual. Every 6 months, sort of giving the lab some feedback about non-specifically or de-identified how the cases are doing, how the kids are doing, to help you better understand what makes your cutoffs meaningful. Some of the ways that, so for example, I've seen a case where it was a novel variant not in Stefan's database. And what helped was not only the very long chain fatty acids, but the ACTH. And so following for adrenal insufficiency. But I think about the conundrum you're bringing up every day. And so I do think there is a definite need for us to be reflective and look back on what we're doing and have the most up-to-date clinical information to annotate what you're finding at birth.
And to add to that, Eric, I remember cases in which you had reported your findings with me and allowed me to add them to the database. Because if you go there, you see that I try to add remarks and comments and references and add data together. I mean, sometimes there is a variant found in the patient, but I know there are experimental papers there in which people used fibrous cell lines, and often that genetic information is there. And if it's the same variant, you can combine the information. So then technically you have a functional assay that you can link. And if Eric emails me that his patient with this particular variant is now showing signs, then I can add that. I mean, it's all de-identified, but I mean, you can use words, language in which it is clear that there is more information on that variant. So it all comes back to sharing and follow up.
Thank you so much, everyone. And thanks, Joe, for that synopsis. I know, like I said, that's a lot of information to have to summarize for us, so thank you. I know some of the families have been mentioning in the chat that they'd like to learn more about this process and may not be familiar with the terminology. So I'll feel free to reach out to me separately, or I can post some links later in the chat too. I know as a newborn screen parent, I've gotten lost in Dr. Kemp's website with all the mutations in a good way, very interesting. So maybe I'll share that as well.